There's this phrase in medicine that always sends a chill down my spine, the silent killer.
Hmm.
We usually hear it about, what, high blood pressure, maybe aneurysms, but in the world of the pancreas, silence is. It's actually much more terrifying. It's almost predatory.
It is. It absolutely is, because by the time the pancreas decides to speak up, by the time you actually feel pain,
Yeah.
it's often way too late. That window has closed.
And that brings us right to the dramatic premise of the sources we are looking at today. So imagine you're a doctor, you're looking at a scan, and you see a cyst in the pancreas, a fluid-filled sac.
Yeah.
To the untrained eye, it's just a bubble. It looks innocent enough,
Huh.
but the sources make it crystal clear that bubble is a high-stakes fork in the road.
Exactly. A high-stakes fork in the road is the perfect way to describe it, because on one path, that cyst is totally harmless, a benign little congenital quirk, or, maybe just a scar from an old injury.
The safe path.
The safe path. But on the other path, it's a silent premalignant trap, as one of the papers put it. It's just waiting to turn into something nasty. Or, even worse, it is the first warning sign of one of the deadliest cancers known to medicine.
So our mission today is to navigate this minefield. We're doing a deep dive into the most clinically dangerous and, let's be honest, exam-relevant zone of the pancreas. We're going to try to classify and understand pancreatic cysts, cystic neoplasms, and finally, the big one, pancreatic carcinoma.
It's a heavy topic for sure, but it's arguably one of the most important deep dives we can do, because accurate classification here is literally a matter of life and death.
How so?
Well, think about it. You miss a dangerous cyst. You miss the chance to cure a lethal cancer. But you overtreat a harmless one. You've just put a patient through a Whipple procedure, which is major surgery for absolutely no reason.
Right, so we need to get this right. Okay, so let's look at the roadmap. We're going to break this down into three main pillars. First up, the non-neoplastic cysts. These are the good guys, or at least the not cancer guys.
Right. The congenital ones and the famous imposters, the pseudocysts.
Then we'll move to pillar two, the cystic neoplasms. These are the specific tumors that range from benign to pre-malignant. We'll talk about serous, mucinous, IPMN, and the solid pseudopapillary neoplasms.
That's the tricky middle ground, the gray zone.
And finally, pillar three, pancreatic carcinoma. We'll look at the genetics, the KRAS and P16 mutations, the precursors like Panin, and those, classic clinical signs that show up on every board exam, like Courvoisier and Trousseau signs.
And before we jump in, I think it's important to highlight what our source material calls the clinical truth. It's a statistical landscape provided by Robbins, and it's really grounding.
Okay.
It says that only 5 to 15% of pancreatic cysts are actually neoplastic.
Which is comforting, right? Most of them are fine.
It is, but here's the twist. Fewer than 5% of all pancreatic neoplasms are cystic.
Okay, wait. Unpack that tension for us. That sounds like a paradox.
It creates this fascinating tension for the clinician. Most cysts you see are going to be safe. They aren't cancer. So statistically, you want to relax.
But you can't.
You can't, because the minority that are neoplastic are potentially lethal. So you can't just dismiss them because the odds are in your favor. But you also have to be really careful not to panic and overtreat. It requires a very cool head and a very sharp eye for detail.
Well, let's sharpen our eyes. Segment 1, non-neoplastic cysts, the safe majority. We're starting with congenital cysts. Now, visually, what are we looking at here on a scan?
Visually, these are usually unilocular, meaning they're just a single chamber. Think of a simple thin-walled sac.
Okay.
In terms of size, they can be anything from microscopic all the way up to about 5 centimeters. And if you took a sample and looked at the lining under a microscope, you'd see a nice, uniform, cuboidal epithelium.
And if it's under pressure?
Right. If the fluid pressure inside is high, that epithelium might look flattened or attenuated, but it's there.
So basically, it's a little balloon filled with clear fluid.
Exactly. Filled with clear, serious fluid. And fundamentally, these are just developmental errors, some kind of anomalous duct development when the organ was forming.
But here's where it gets interesting for me. The sources mention that while these can just, happen randomly, they're often a check engine light for a bigger systemic problem.
Yes, that is the critical association. These cysts are often part of larger hereditary conditions. Specifically, two big ones: autosomal dominant polycystic kidney disease and von Hippel-Lindau disease.
Let's connect those dots. If I have a patient who comes in with polycystic kidney disease, I shouldn't just be looking at their kidneys.
Correct. We tend to get tunnel vision in medicine. We think, oh, it's a kidney disease. Let's just look at the kidneys. But in polycystic kidney disease, these cysts can coexist in the kidney, the liver, and the pancreas. It's a multi-organ thing.
And the same goes for von Hippel-Lindau, right? VHL.
Even more so with VHL. In von Hippel-Lindau disease, you have this whole constellation of vascular neoplasms in the retina and cerebellum. Those are hemangioblastomas.
Yeah.
But you also get cysts and neoplasms in the pancreas, liver, and kidney.
So finding a congenital cyst in the pancreas could actually be the clue that leads you to diagnose a brain tumor or a kidney issue somewhere else.
Precisely. It's a huge reminder that the pancreas doesn't exist in a vacuum. It's part of a whole body system.
So that's the congenital side. But now we have to talk about the heavyweight champion of this category, the pseudocyst. Our sources are very clear. These account for 75% of all pancreatic cysts. They are the dominant type.
They really are.
But the name has always bothered me. Pseudo. It feels like it's accusing the cyst of lying or something.
Well, in a way it is. A true cyst, biologically speaking, has a strict rule. It must be lined by epithelial cells. It's a neat, organized structure. A pseudocyst breaks that rule.
So if there's no epithelium, what's holding the fluid in? And what even is that fluid? This brings us to the origin story, which, frankly, sounds pretty violent.
It is a story of violence. Pseudocysts are born from chaos. They almost always form after a bout of acute pancreatitis, particularly when it's superimposed on chronic alcoholic pancreatitis.
Or trauma.
Or, yeah, they could arise from traumatic injury to the pancreas, like a steering wheel injury in a car crash.
So what's happening inside the organ during that chaos?
You have to remember what the pancreas is. It's a bag of incredibly potent enzymes that are designed to digest steak and fat. When you get pancreatitis or trauma, those enzymes leak out. They start digesting the pancreas itself. It's enzymatic fat necrosis.
It's basically the acid blood from the movie Alien. It's melting the tissue from the inside out.
That is a perfect analogy. That's exactly what's happening. It's melting the fat and tissue around it, creating this slurry of hemorrhagic debris and dead tissue.
Yeah.
The body, realizing it can't heal this immediately, goes into damage control mode. It just tries to contain the spill.
So it builds a sarcophagus around the mess.
Exactly. It walls off that necrotic hemorrhagic area with fibrosis, that's scar tissue and granulation tissue. So when you look at the wall of a pseudocyst, you aren't seeing a nice epithelial lining. You're seeing a fibrous scar holding back a lake of enzymatic fluid. That is why it's pseudo.
And these things can get massive, right? I mean, we aren't talking about pimples here.
No, we are talking about serious volume. They can range from 2 centimeters all the way up to 30 centimeters.
30 centimeters. That is like having a basketball inside your abdomen.
It's huge. And because they're essentially these walled-off fluid collections, they can show up in various places. They might be within the pancreas itself, but commonly they're found in the lesser omental sac or the retroperitoneum, between the stomach and transverse colon. They can even be subdiaphragmatic.
A 30-centimeter fluid sac sounds, well, problematic, even if it's not cancer.
It certainly is. While many pseudocysts do resolve spontaneously, the body eventually reabsorbs the fluid and the inflammation quiets down, they carry very real risks. They can get infected, turning into a massive abscess. Or, if they get large enough, they can compress adjacent structures. Or worse, they can perforate.
Perforate into where?
Into the abdominal cavity, causing peritonitis, or even into adjacent organs. Imagine a large cyst just bursting. That is a surgical emergency. So even though it's benign in terms of cancer risk, it is definitely not harmless.
Okay, so quick recap for the listener before we move on. Pseudocyst equals 75% of cases caused by the violence of pancreatitis or trauma, and the magic password is no epithelial lining.
You've got it. That covers the non-neoplastic side pretty well. Now we have to cross the border into the danger zone. Segment 2, cystic neoplasms.
This is that 5 to 15% slice of the pie. The sources describe a real spectrum of risk here, ranging from mostly harmless to a ticking time bomb. Let's start with the benign one, the nice guy of the group, the serocystic neoplasm.
Right. Serocystic neoplasms are pretty much the good news diagnosis in this category. They are almost always benign.
And there's a very specific visual associated with these. I keep seeing the word honeycomb in the notes.
Yes, that is the classic description. These tumors are usually composed of many, many small cysts, about 1 to 3 millimeters each. So when you look at a cross-section, it doesn't look like one big balloon. It looks like a sponge or a honeycomb. We call it honeycomb microcystic.
And they are filled with that straw-colored fluid again.
Yep. Thin, watery, serous fluid. Very similar to the congenital cysts in that way. but the structure is this unique sponge-like mass.
And where do we usually find them? Is location a clue here?
Location is absolutely a clue. These are usually found in the tail of the pancreas.
Okay, so tail plus honeycomb usually equals serous. What about the patient profile? Any demographic tells?
They're about twice as common in women, and often they're just found incidentally. A patient gets a scan for something else, maybe kidney stones or back pain, and there it is.
And is there a genetic component here? We mentioned VHL earlier with the congenital cyst. Does that make a comeback?
It does. The most common genetic abnormality in serous cystic neoplasms is the inactivation of the VHL tumor suppressor gene. So again, we see that genetic link to von Hippel-Lindau disease even in these sporadic tumors. It tells us something important about the pathway that's broken.
So the takeaway for serous is benign, tail, microcystic honeycomb, VHL. Got it. Now let's pivot to something darker. The mucinous cystic neoplasm, or MCN, our source calls this a precursor to invasive carcinoma.
This is where we have to be vigilant. Unlike the serous type, the mucinous cystic neoplasm is a dangerous chameleon. It can absolutely turn into invasive cancer.
And the demographic shift here is pretty dramatic. We went from twice as common in women for serous to
almost exclusively women. 95% of mucinous cystic neoplasms arise in women. If you see this diagnosis in a man, you should probably double-check the slide. It is a female pathology.
and location, still the tail.
Like the serous type, these are also usually in the tail of the pancreas.
Okay, so we have a cyst in the tail of a woman. It could be serous, which is benign, or it could be mucinous, which is potentially cancer. How do we tell them apart? The histology apparently has a massive aha moment.
It does. It's one of the strangest and coolest features in all of pathology.
Lay it on us.
Okay, so mucinous cystic neoplasms are lined by a columnar mucin-producing epithelium. That part's expected, it's in the name. But underneath that lining, there is a dense stroma, the supporting tissue, that looks exactly like ovarian stroma.
Wait, pause. Ovarian stroma in the pancreas.
Yes.
The pancreas is in the upper abdomen. The ovaries are decidedly not. How on earth does ovarian tissue end up inside a pancreatic tumor?
It is bizarre, isn't it?
Yeah.
But it's diagnostic. If you see that stroma, it is an MCN, full stop. The prevailing theory is that during embryology, when the fetus is developing, the genital ridge, which makes the ovaries, and the dorsal pancreatic bud are actually very close neighbors.
So it's a construction site mix-up. A few cells get left behind.
That's the best analogy. Some cells get lost. This ectopic tissue gets trapped in the pancreas, lies dormant for decades, and then, perhaps driven by hormones later in life, it wakes up and forms a cyst. And that's why it has estrogen and progesterone receptors, just like ovarian tissue.
That is wild, and it explains the 95% female demographic perfectly.
Right. It connects the biology to the epidemiology in a really elegant way.
And the content is different too, I assume. Sierra's had that watery, straw-colored fluid.
Right. MCNs are filled with thick, tenacious mucin. It's goopy.
What about the genetics here? We're not talking about VHL anymore, are we?
No. Now we start seeing the darker mutations. You often see KRAS mutations in about half of cases.
Yeah.
And if the cyst starts becoming invasive, turning into frank cancer, that's when you see TP53 and SMAD4 mutations appearing.
So the prognosis depends heavily then on when you catch it.
Entirely. If you catch it while it's non-invasive, surgical resection is curative. You take it out, the patient is fine, but, and this is a big but, if it has already become invasive, the prognosis just drops off a cliff. Invasive cases have a 50% 5-year mortality. So spotting that ovarian stroma on a biopsy before it invades is absolutely critical.
Okay, next up is a mouthful. Intraductal papillary mucinous neoplasm, or IPMN. Now, this sounds a lot like MCN's brother. How does this distinguish itself?
It helps to think of them as counterparts. Contrast is definitely the best way to learn this. First, while MCN is almost all women, IPMN is more common in men. Second, while MCN loves the tail, IPMN tends to involve the head of the pancreas.
And I'm guessing the name intraductal gives away the big structural difference.
Exactly. The key distinction is the involvement of the pancreatic duct.
Yeah.
MCNs do not communicate with the duct system. They're separate, walled-off structures. IPMNs grow within the ducts. They're connected to the plumbing, so to speak.
And do they have that weird ovarian stroma?
No, and that is the clincher. IPMNs lack ovarian stroma.
So, men, head, duct involvement, no ovarian stroma. Is there a genetic marker that really sets IPMN apart?
Yes. Along with KRS, which we see pretty often in these, IPMNs have gene AS mutations in about 2/3 of cases. That gene AS mutation is a key differentiator. You just don't see that in the other types.
We have one more in this category, the solid pseudopapillary neoplasm. This one seems a bit like the odd one out.
It is the outlier. It typically occurs in young women. We're talking 20s and 30s. It usually presents as a large mass that's causing abdominal discomfort just from its size. And visually, it has both solid and cystic components, often with hemorrhagic debris inside.
And the genetics are unique too.
Very unique. It has a very specific signature, activating mutations in CTNB1, which is the gene for beta-catenin. You don't see the KRAS or GNAS mutations here. It's its own beast, biologically speaking.
And the outlook for the patient.
Generally, quite good.
Yeah.
Surgical resection is usually curative, so despite looking scary and large on a scan, it's very treatable.
So that wraps up the cystic neoplasms. We've gone from the benign serous honeycomb to the risky ovarian-like MCN to the ductal IPMN in men, and finally the solid pseudopapillary in young women. But now we have to talk about the monster under the bed. Segment 3, pancreatic carcinoma.
This is the lethal diagnosis. This is the one that every doctor, every patient dreads finding. To set the stage, pancreatic cancer is the third leading cause of cancer deaths in the U.S. It has one of the highest mortality rates of any cancer. The 5-year survival is just hovering around 10%. It's aggressive, and it is unforgiving.
And it doesn't just appear out of nowhere. It starts small.
Yeah.
Let's talk about the precursor, Panin.
Right. Invasive cancers don't just pop into existence. They evolve. The precursor lesions are called pancreatic intraepithelial neoplasia, or PANNs. These are microscopic lesions in the small ducts. And Robbins states that greater than 90% of pancreatic cancers arise from these tiny PANN lesions.
It's like a ladder of bad news. The source details a progression model of mutations. And I really want to slow down here because understanding the sequence is key to understanding the cancer. I like to picture a car speeding down a highway.
That's a classic analogy for oncology. Let's roll with it.
Okay, so normally the cell drives at the speed limit. It stops when it's supposed to. What is the very first thing that goes wrong?
The first thing that happens in over 90% of cases is a mutation in a gene called KRS. KRAS is an oncogene. In our car analogy, KRAS is the gas pedal.
And the mutation bricks the pedal to the floor.
Exactly. The mutation activates it permanently. The cell gets a constant, unrelenting signal. Grow, divide, go. It can't stop accelerating. This happens very, very early in the process.
But usually a car has brakes.
Right. And your body has tumor suppressor genes that act as brakes. The first major one to go in pancreatic cancer is called CDKN2A, which produces a protein called P16. Think of P16 as the brakes.
So now we have KRS pushing the gas pedal to the floor, and the P16 mutation has cut the brake lines.
Precisely. So now you have a cell that is proliferating out of control. It's speeding, but it hasn't crashed yet. This is the intermediate stage.
What causes the crash? What finally turns it into invasive cancer?
The crash happens when you lose the guardian of the genome, a gene called TP53. TP53 is like the steering wheel and the airbags combined. It detects damage and tells the car to either pull over for repairs, which is cell cycle arrest, or to just junk itself, which is apoptosis.
And when TP53 is gone,
The cell stops caring about DNA damage, becomes wildly unstable. Then you add in the loss of another tumor suppressor, SM84, and the car is now a twisted wreck, plowing through the guardrails. It becomes invasive. It invades nerves, it invades vessels and surrounding tissue. That is the molecular story of pancreatic carcinoma. KRAS, P16, TP53, SM84, in that order.
that is a terrifyingly clear picture. Let's talk about who is at risk. What are the factors that push someone onto this particular highway?
Well, age is the biggest one. 80% of cases are after age 60. But environmentally, the strongest influence is cigarette smoking. It doubles the risk.
Doubles it. That is a significant number.
It's huge. Then you have things like chronic pancreatitis and visceral obesity. But there is a clinical pearl here that I want every listener to burn into their memory. This is something that gets missed all the time in primary care.
This is the detective clue I mentioned in the intro.
Yes, it's new onset diabetes in an older patient.
Walk us through that. Why is that such a massive red flag?
Diabetes usually develops slowly over time. It's often associated with obesity, family history. But if you have an elderly patient who's not particularly obese, has no family history of diabetes, and suddenly out of the blue develops diabetes, alarm bells should be ringing at maximum volume.
Why? What is the cancer doing to cause that?
The growing tumor in the pancreas can affect the islet cells or cause fibrosis that disrupts insulin regulation long before it causes a mass big enough to feel or see easily. So that sudden onset of diabetes might be the first and sometimes the only indication of an occult pancreatic cancer.
That is huge. A sudden diabetic diagnosis could be a mask for cancer?
Exactly. We call it the canary in the coal mine. If you catch it then, you might actually have a chance at a cure.
Before we move on, you mentioned BRCA2 earlier in the genetics section. I think most people associate that with breast cancer. Why is it here?
It's crucial here, too. BRCA2 is the most common cause of familial pancreatic cancer. About 10% of pancreatic cancers have a hereditary component, and BRCA2 is the main player. That's why germline testing is now recommended for patients with pancreatic cancer. It has huge implications for their families, for their kids.
Okay, moving to segment 4, clinical presentation and morphology. Where are these tumors usually sitting in the pancreas?
About 60% arise in the head of the pancreas, another 15% in the body, 5% in the tail. The fact that most are in the head is actually clinically very important for the symptoms.
And what do they look like? If a surgeon opens someone up, what are they seeing?
They see a hard, stellate gray-white mass. The key word is hard. You'll hear surgeons say it feels like a rock. And this is due to something called desmoplasia.
Desmoplasia. That's a great word. Break it down for us.
It refers to the intense fibrotic reaction the tumor creates around itself. The cancer cells trick the body's own cells into laying down massive amounts of dense scar tissue. It's like the tumor is building a concrete fortress. This makes it hard to the touch, but it also makes it incredibly hard for chemotherapy drugs to penetrate.
And it's invasive.
Highly invasive. It famously invades nerves. We call that perineural invasion. This is why pancreatic cancer is so notoriously painful. It is literally growing into the nerves themselves. It also invades vessels and the retroperitoneum.
You mentioned pain. That's usually the first symptom, right?
It is, but the real tragedy is that by the time pain appears, it's often too late for a cure. It means the cancer has already grown large enough to invade the nerves or the retroperitoneum.
But there's a difference depending on location. You said 60% are in the head. Does that location offer a different, maybe earlier warning sign?
Yes, and this is the one glimmer of hope in this whole story. Tumors in the head of the pancreas can physically obstruct the common bile duct as it passes through, and this leads to obstructive jaundice. The patient turns yellow.
So ironically, turning yellow is a good thing.
In this context, yes, because jaundice is visible. It might alert the patient or their family before the tumor has spread too far. Painless jaundice is a classic presentation for tumors in the head of the pancreas.
And this leads us to 2 classic medical school signs, the exam favorites. Let's start with Courvoisier's sign.
Right, Courvoisier's sign is a very specific clinical finding. A palpably enlarged, non-tender gallbladder accompanied by mild, painless jaundice.
Why non-tender? That seems to be a crucial distinction.
It is the key. Think about gallstones, the other common reason you get gallbladder issues. If you have a stone blocking the ducts, the gallbladder is acutely inflamed. It hurts a lot. If you press on it, the patient screams. That's Murphy's sign.
But with pancreatic cancer, it's different.
With pancreatic cancer, the obstruction is slow and progressive. It's like a slow drain clog, not a sudden blockage. So the gallbladder swells up like a balloon filled with bile. It gets huge. You can actually feel it from the outside. But because it's not acutely infected or inflamed initially, it's not painful to the touch.
So, big painless gallbladder plus yellow skin equals look for a tumor in the pancreatic head.
That's the sign.
And the second one, Trousseau sign. This one sounds like a magic trick. Migratory thrombophlebitis.
It does sound strange. Trousseau sign is when you see blood clots thrombosis appearing in different veins, moving from one location to another. One week you might have a clot in your left leg. The next week it's in your right arm. It occurs in about 10% of patients.
Why on earth is the blood clotting like that?
The tumor itself releases procoagulant factors into the blood. It's dumping chemicals, specifically platelet-activating factors and mucins, that make the blood sticky and hypercoagulable.
So the cancer is literally changing the chemistry of the patient's blood from afar.
Yes. And there is a tragic historical footnote here. Armand Trousseau, the French physician who described this sign, actually diagnosed himself with pancreatic cancer after he noticed these migratory clots in his own body.
Wow. Talk about a grim realization. From a silent trap to migratory blood clots. This disease really has a sinister toolkit.
It does. It forces us to be incredibly observant. It demands that we look for the subtle signs, the new diabetes, the painless jaundice, the strange clots.
We have covered a massive amount of ground today. We've gone from these harmless bubbles to the lethal rocks. Let's do a rapid recap to cement these high-yield associations before we go. I'll throw the term at you. You give me the key association.
Let's do it.
Pseudocyst.
No epithelial lining. 75% of all cysts born from the violence of pancreatitis.
Serous cystic neoplasm.
Benign. Tail location. Honeycomb. Microcystic appearance. VHL gene.
Mucinous cystic neoplasm. MCN.
Women. tail, and the mysterious ovarian stroma, that's the big one, and it's pre-malignant.
IPMM.
Men, hit location, duct involvement, GNAS mutation,
Solid pseudopapillary.
young women, beta-catenin mutation, good prognosis.
And finally, pancreatic carcinoma.
Lethal, the KRAS driver, the gas pedal, then P16, the brakes, the DP53, the steering, progression, and Courvoisier's sign, that painless gallbladder.
Yeah, that one final thought to leave our listeners with, something to mull over.
I'll go back to the new onset diabetes. In a world of information overload, that is a signal-to-noise champion. If you see diabetes appear out of nowhere in an older person, do not just treat the sugar. Look at the pancreas. It might just save their life.
Powerful advice. There's so much more we could cover: staging, biopsy differentiation, tumor markers like CA19 and 9B, but we will save those for a future deep dive. For now, take those aha moments, the ovarian stroma, the honeycomb, the painless gallbladder, and file them away. You never know when you'll need them.
Thanks for listening to this deep dive into the pancreas.
Stay curious and keep connecting the dots.